So good afternoon, everyone. I want to welcome you to today's panel discussion. Happy Pride Month to you. My name is Carlin Obringer, and I serve as Government and Community Engagement Manager with Blue Shield of California. It's my pleasure to welcome everyone to today's virtual panel. And on this last day of Pride, we're going to be discussing the importance of culturally responsive and inclusive mental and physical health care for LGBTQ plus youth. And why is this conversation important? Because culturally responsive mental and physical health care is life-saving. We understand that if a young person has a negative healthcare experience, they will avoid mental and physical health care, which can lead to a shortened lifespan. And so our goal today is to convene this conversation to raise awareness around this important topic and generate ideas through our conversation for effective systems change. And for those who don't know, Blue Shield of California has been working to support LGBTQ plus youth via grant funding to organizations like the Oakland LGBTQ Center for Youth Programming, and by developing an LGBTQ plus youth mental health guide. And we do have that available. And I will put this information in the Q&A for all to be able to reference later. It's https://bluesky.blueshieldca.com. And speaking of Blue Shield of California's Blue Sky initiative that was launched in 2019, Blue Sky aims to address the huge needs and gaps in California youth mental health supports. And I'm sure many are familiar with the nonprofit organization Children Now. They do an annual report card. And in that report card, mental health is the #1 reason for youth hospitalization. So we're working to address that. Blue Sky is designed around 3 pillars: access, awareness, and advocacy. And just a few outcomes I'll share with you. We've been tracking our work in this area from August 2019 through March 2021. And so we've been able through this program to serve 866 youth through individual, group, and family sessions. We've had nearly 7,000 counseling sessions completed and 25 wellness sessions completed. So this has resulted in a 10% plus overall improvement from pre to post-test. And that includes in the areas of affective strengths, intrapersonal strengths, and interpersonal strengths. So just wanted to share some of that context with you. And one quick housekeeping item for our attendees before I turn this over to our panel facilitator. I just want folks to realize we don't have a chat, but we do have Q&A. So please use the Q&A for your questions. I will monitor them and pull from there for the Q&A section of this webinar. And now, it's my pleasure to introduce David W. Bond. He's the Director of Behavioral Health for Blue Shield of California, and today's panel and discussion facilitator. And David's a licensed clinical social worker, board certified expert in traumatic stress, and here at Blue Shield, he leads initiatives to restore, sustain, and enhance the behavioral health and well-being of California's Medi-Cal and Medicare beneficiaries. So, David, I'm going to turn it over to you to introduce the panelists and facilitate our questions after that.
Great. Thank you very much. And thank you for inviting me to host today's panel. When Carlin asked me to come and participate today, I was like, yeah, sure, no problem. I love this topic. I love this concept. And I really enjoy being on panels as well as moderating them. And then she sent me everyone's bio and said, here you go. Why don't you maybe come up with a couple of questions that are relevant to some of these backgrounds? And I was like, yeah, sure, no problem. And then I read the bios of this panel and I was like, holy cow, these are some qualified people on these topics. How am I going to come up with some questions that are like, you know, a little bit provocative, intriguing, and interesting to them and to the crowd? So what I'd like to do is, as I go through, I'm going to introduce everyone. I have 2 things I want to mention. One, I'm going to be saying some of these names out loud for the first time. So if I mispronounce your name, please correct me and I'll get it right the second time. The other thing I want to mention is I'll ask some pretty pointed questions. But if there's something else that you're like, what I really want to talk about is this, add on to the question that I ask you, please. so that it's not just me directing everything that everyone says based on the narrow question that I might ask. Right? So I'd like to invite all of that. And then also at the end of anybody's response to a question, I would like, if anybody has like a follow-up or an additional or like a +1 that they want to add to something that someone else contributed, go for it. Although I will be looking at time to make sure that I give some equal time to everyone so that we don't have to lose out on anybody at the end of the questions that I direct, right? So first, I'm going to go through and introduce the panel. Again, if I get your name wrong, please like stop and correct me and I'll get it right the second time. But first, I want to introduce Jicara Collins, who is our public health program manager over clinic health education team at Contra Costa Health Services school-based clinic program. Jicara works very closely with health services and school district personnel and community partners to continue to ensure optimal health and well-being of the youth in Contra Costa County and affecting greater change. We also have Gigi Crowder, and Gigi is the NAMI Contra Costa Executive Director. Gigi works hard to promote the use of community-defined strategies for all unserved, underserved, and inappropriately served ethnic and cultural communities. Her current focus is addressing the needs of the African American community, specifically those who are negatively impacted by systemic racism and exposure to trauma. NAMI is the National Association for Mental Illness. Kanwarpal Dahliwal, co-founder and associate director of the RYSE Center. RYSE Center? RYSE Center. RYSE? RYSE.
Right.
Yes.
The RYSE Center. As associate director, she supports and guides the implementation and integration of healing-centered practices grounded in racial justice and liberation across all of RYSE's program areas. Kanwarpal believes that the purpose of her work and life is to contribute to movements, communities, and legacies of liberation that honor the ancestors who fought for her existence and survival, and to forge a world that is just and gentle for future generations. Kiku Johnson is at the Rainbow Community Center of Contra Costa and is the executive director there. Kiku has 30 years of experience with youth development and responsive community program design, outreach, implementation, impact, evaluation, and advocacy through a social justice lens. That's something I think a lot of people would make an acronym about that would be way too long. Okay. Kiku is independently and collaboratively adept at creating culturally and trauma-informed, accessible, affirming approaches and content for a wide variety of intersectional communities, including LGBTQI+, people of color, youth, and adults, working across sectors including juvenile justice, education, mental health, community-based and faith-based organizations. And we have Gerold Loenicker, who is a marriage and family therapist and the program chief of child and adolescent mental health in Contra Costa Behavioral Health Services. Gerold has worked in community mental health for the past 20 years, both within community-based organizations and for the last 13 years for Contra County Behavioral Health. Through his work in diverse settings with diverse groups of clients, Gerold has come to appreciate the importance of cultural humility and the willingness to continually examine one's own assumptions and biases. And finally, I have the pleasure of introducing Lynn Mackey, who is the County Superintendent of Schools for Contra Costa County Office of Education. Lynn was elected as the Contra Costa County Superintendent of Schools in November in 2018. Her education experience has influenced her career as an educator and desire to foster supportive education environments for students of all backgrounds. Okay. So I'm looking through and making sure that I didn't leave anybody out from this list. Great. So welcome to all of you, and thank you so much for joining us today on this last Wednesday of Pride Month. Although I live in San Diego, so our Pride is actually in July. We're actually getting a bit of a Pride. We don't have a parade, but we do have a block party. So we're just gradually coming out of the COVID, no official Pride events. But I would like to go ahead and first direct a question to Jicara. No, I'm sorry. I was looking at the wrong page. My first question is actually for Gigi. Gigi, your bio notes your focus on the underserved, the unserved, and the inappropriately served. And that definitely raised my eyebrow. Can you talk to us a bit, please, about what it means to be inappropriately served? Um, and how does your work and the work of NAMI seek to help toward healing for these groups of people?
So when I started my work in Alameda County as their ethnic services manager, we got clear mandates from the state that we were to serve the unserved and underserved. Yet I looked at our system of care and I recognized that although we were serving some individuals who fit that category, we weren't doing it in a way that would produce the best outcomes. So we championed the state to include inappropriately served. If you're an individual from the LGBT community and you don't have services that speak to your need, then you may be going and getting mental health services, but they're not being delivered in a manner consistent with producing the best outcome. So that's the simple answer for inappropriately served. We also see that in other ethnic and cultural communities, but we most often see it for the LGBTQ plus community because we have such a one size fit all and we don't peel back the onion to go through the layers and really connect with some of the challenges that are being faced by individuals who have mental health struggles, but also are asked to leave a big part of who they are behind in their conversations with therapists.
Gigi, one of your, also in reading your bio, I see that you work quite a bit with faith-based modalities. And faith-based modalities can really mean a lot of different things, particularly to the LGBTQI community, or LGBTQI communities, I should say. And sometimes haven't always been aligned. Can you talk a little bit about how in your work with faith-based organizations, how you, and communities, how do you bridge that gap between what may not historically have been a really closely aligned partnership or supportive role between faith-based and LGBTQI populations?
I think it has not really been challenging for me because I have a foundation of principles that I learned from and I am taught of. And so I don't think it's any different from individuals who claim to be people of great faith and are racist. So as I started working with these communities, I started lifting up the foundation that I believe in. And I found that, wait, some of this narrative about the divide isn't true. Because some of the folks that I've been working with are embraced and they go to very affirming faith centered, and maybe it's about funding. And if we say that we can't work with this community, maybe we don't have to fund this community, because I noticed when I was doing some work, and I won't name the county, it was an automatic, oh, we didn't reach out to this community because we knew they were not going to be willing to work. And it wasn't true at all. They are not going to be willing. That was just a false narrative. That's a part of steeped in racism more than it is in homophobia. And so I have on my staff several individuals that are probably more connected to their faith than I am. And they also identify as LGBTQ. And we talk about it all the time, how that false narrative could hurt communities. And I'll say for myself, especially the African-American community, but whenever I've gone into having deep conversations with individuals, it's been proven to be a false narrative that I just refuse to lift up because it's just a part of systemic racism. So that answered the question.
No, I definitely appreciate that. I wonder, like, what would you say to young LGBTQ folks who may be interested in exploring faith-based modalities or faith-based support for who they are, but have struggled with some feelings of rejection?
It would be the same conversation I would have with individuals who live with mental illness and are rejected when they go into faith communities. Find a mental health friendly community that's embracing of all of who you are. And if you run into someone who's promoting stigma and discrimination towards you, throw the scriptures back in their face that support where you are. So, okay, I'm kind of rebellious in my approach to shift in thought patterns, but I wouldn't want to be anywhere I'm not welcome. I don't encourage people to go anywhere, but I always lift up teachable moments. So if someone comes to me and say, hey, this happened there, I've been known to get on Facebook and have a battle with some of the leading faith leaders in our region. And I usually win. They stop before I do.
Practicing inclusions shouldn't be such a radical concept.
No, it shouldn't be.
Thanks.
I like mental illness. I think we've made great progress over the 10, 15 years of being more understanding and embracing individuals. I don't use the word tolerance because that undermines what we're working toward. But I do think that mental illness affects 1 in 4 families. And so most families have a loved one that they that identifies within their family. So I think that the narratives, we just have to break them down. We've made great progress, and one-on-one conversations reveal that there's more programs around acceptance, and they're really making a difference.
Good, thanks. And I agree. Tolerance is tolerance used to be the right word to use, but then we realized that it wasn't just something that we need to tolerate, but we need to actually learn and understand to really practice inclusion.
Yes.
That actually leads me into Kanwarpal's. Kanwarpal, please say your name once for me, because I'm afraid that I might not be saying it correctly. It's new for me.
I appreciate the attempt. Very close. Kanwarpal.
Kanwarpal. Okay, thank you. Well, this really kind of leads right into the question that I wanted to pose for you. When we look at social justice isn't a new concept, but a lot of people are talking about it and understanding it a whole lot more over the last year than I think even previous to in before 2020. So as we address culturally competent care, I think we would really be amiss to not include the concept of social justice informed behavioral health services. So I wonder if you could talk to us a bit about what that might look like, and do you see any shifts based on the real awakening for many people over the last year that would contribute to this concept of social justice informed behavioral health care and access?
Yeah, well, thank you for having me here, having RYSE here. Also, I just really appreciate all the things Gigi lifts up around. So much of this is around racist, classist, sexist narratives, especially of our Black kin and our brown kin. And I think even thinking about a social injustice informed behavioral health, that part of how we have to break that up is even like question, why are we focusing on behavior when what we know about distress is actually about social conditions and about oppression and supremacy and the intersections of supremacy and the intersections of entitlement. And so we don't even sort of talk about it as behavioral care. For us, it's about healing, it's about organizing, it's about building power and building loving power. And so, I think part of, something we say as an organization, especially as the trauma-informed industry is growing, is if it's not racially just, we can't call it trauma-informed. And I think it's important that we make space for everyone to be able to enter and arrive. And I also want to acknowledge, I don't know when tolerance was actually okay. I've never been in those spaces or places, or if I was taught and told and still, included. So I would also want to sort of, question that, like, who got to decide that tolerance was okay? Because it certainly was the people I'm committed to and who were committed to me. And then the other thing I want to say, I think, is around like social justice informed. It's like, it needs to be embedded, imbued, like this work is justice work. So all of it is justice. And so, and I will also share for young people at RYSE, what we know and what we hear from them for young people who identify as LGBTQ+ and queer, is that where they find so much hope and affirmation and nourishment is in their faith. and is in like how they build community. And they grapple with all the things it might mean, but that they actually really hold up faith as what keeps them going. And I think as an organization, it's really important. We are not a faith-based organization, but our job is to uphold what works for young people, and where they find that hope, that healing, that power, and make sure that that is sustained for them. And having whenever hard conversations, like Gigi said, might come up. We might have to go to city council. We might have to call somebody, but that's what we've chosen to do and we're trusted to do. I'll stop there because I can keep going.
Well, I appreciate that one too. I think that word tolerance as an evolution too. I appreciate what you said, and as I think about it, I think I was projecting a little bit onto my question over to Gigi, because of having been raised in the Mormon Church, for example, and having my own journey out of what it took to tolerate myself and then accept myself and then love. So I appreciate that call out for the words, and we'll definitely have to keep that one in mind. Let me ask you this question too. What would it look like for, let's say, a therapist or someone who's practicing mental health? What would it look like and feel like if it was really on the right side of being social justice informed?
I think the right side is that we would name race explicitly, and intersectionally. And it would be that we are not tethered and contorting to a system of financing around Medi-Cal or Medicaid. Those resources already belong to our communities. So it shouldn't be so difficult to get what already belongs to us. And so it would look like that. And we would eliminate a diagnosis threshold in order to get services, so that we are not working from proof of pain, but sort of like an ecosystem and ethos of care and tending.
Great. Thank you. Okay, lots to absorb in that one. I think this leans into, as we talk about systems of care too, leans into a question that I have for Lynn Mackey. So from the school perspective, what resources do schools need to best equip them to serve LGBTQ youth? And what barriers or success stories could you tell us about matching schools with what they need?
Thank you, David, and thank you for that question. You know, when Carlin first reached out to me, I was thinking, I am not qualified to be on this panel because it's about healthcare. I thought of it as like, this is a healthcare panel. I'm in education. What am I going to say? And then, you know, when I think about the whole child, the whole student, developing a inclusive campus leads to better health outcomes, right? So an inclusive, supporting, affirming, empowering school campus, whether we're talking about the healthcare end of things, because now schools are traditionally more about whole student care. We do have some community school models in our county where students get their medical, emotional, all their health care needs at the school campuses. And so schools, you know, so then I got, okay, that's where the place that I'm going to go to is, which is a school campus look like that is inclusive and supportive. You know, when I first started kind of digging into it, I was talking to one of our school nurses at a school where I think we do it pretty well. We're very inclusive. We have a proportionally high number of LGBTQ students who through surveys indicate that they are cared for, supported, and feel seen and heard. And I was just asking, how do we do that well? And earlier today in the conversation, somebody mentioned, I think the study we were talking about was the one that recently where it talked about just like a GSA and how that really, just having one on campus really helps with health disparities and health outcomes. And so we do that. We try to have, even though it's like 90% of school nurses and school health professionals are women, and then like 70% are white women, right? And teachers are almost the same, when even though we know that in order to have a really inclusive, whether it's racially inclusive or LGBTQ, you need representation of people so they can see themselves in the people providing the services, which is challenging. So that is one of our resources that we need to better develop a pipeline and a platform for people wanting to come into the school space and teach, people of color, people LGBTQ, which means we need to have a safe space where they'd want to come work, for one, right? And so that goes to having some really clear, clean policies at a school around, you know, looking at your bullying policies, your harassment policies, and being really explicit about it, like being really like, what was said about being really explicit about race and right? We need to like call it out, and we need to do the same around LGBTQ. Like, here are our policies, and we're going to talk about it. You know, there's a number of, you know, we just got recently our Healthy Kids survey, which is a survey that schools use to look at the well-being of students, right? And the 1920 and soon the 20, and they break it out. There is now broken out by LGBTQ, and then they do it countywide. And like in our county, 66% of students who identify as LGBTQ, you know, self-disclose a deep sense of sadness on a regular basis, chronic sadness. And like, so we need policies in place where we really look at that. And it's like 21,000 did the survey, and of that, it's like 1,600 self-identified as LGBTQ. To me, that's a small subset that we need to really engage and talk to people and talk to youth and get the supports in place that they need to not, you know, so that we can heal that. I'm going on, and I could go on and on, so I don't even know if I answered the question.
Well, I think that what you touched on first was really like the need for visibility and representation, and that really uplifts a school's capability of serving all of the students who attend there. The other piece of it too, I think, when you're talking about and surveys for LGBTQ people, they're so complicated when you talk about metrics and measurement. When I was a child, they would talk about like the Kinsey scale, and it was like 10%. And then there was this reduction to like, actually, it's probably closer to like 3 to 4%. And it's so difficult to count or measure or create a census for anything other than, you know, when you talk about LGBTQ, and then sometimes referred to as the alphabet mafia, the more you expand that, the more of us there are, right? There's also that concept of, if you survey students and ask, or anybody really, and say, are you completely straight, mostly straight, bi or pan, mostly gay, or completely gay, you get a whole lot more than 10% of people answering that there's something other than completely straight. So then you're like, well, does that mean that all those people are LGBTQ? And then are you really asking the right people the right questions when you're talking about what is your pervasive mood or your perception of safety at school or at home, you know, relevant to these identities intersecting with race, financial status, or your, you know, like your poverty status, or your health status, or your ability status, and others. So I'm sorry. So I've gone on and on now too, just kind of layering in with what you were talking about in terms of the school's ability to really understand all variety of youth and provide culturally competent, social justice informed, race informed, and equity informed education, and then care. There's so many complexities. In the schools that you work with, could you give an example of like, what are some schools doing that are really hitting the mark in terms of educating their faculty and staff or parents, or providing those kinds of improved healthcare services or education services to LGBTQI youth?
So a couple of schools that come to mind. One is one that we run at the county office, who it was the one that when I said I feel like we're hitting the mark, because the students say they feel safe and seen and want to come back to school. And, you know, Learning for Justice has like a toolkit for how to have best practices for serving LGBTQ students. And right, it's just almost like a checklist that you look at your curriculum. So, you know, just adopting like a history curriculum right now, you can't really do that because there isn't a good one, right? So you have to really explore it and develop curriculum that is more inclusive to everyone. So we do that. We have like a curriculum committee that looks at it through multiple lenses. We have a GSA, we have a gay straight alliance. We have representation, staff representation who are open and out and affirming. We go through, when we look at our policies, right? We were just updating our policies and we're like, okay, how do we have it so it is, this old policy had, you know, he, she, or, you know, and it was like, how do we have it so everybody is included in this policy? So it really is being mindful and like going through it and like, and then doing the training. This is a big challenge in schools, is to train staff because of the limited amount of time and resources around staff development. But it is making that a priority just as much as a priority as the academics, and to make it a priority that it is not just the teaching staff, but it is all the staff that work with youth are getting trained and on a regular basis, that it's, and also that it goes deeper. I was just recently talking with the head of the local university that does a lot of teacher training, and they are trying to embed all of this into the pre-teaching credential program, so that it's not like something new when they come to a school site and then they have to be trained on everything, you know.
So it's not just like a one training and we've checked the box and now we are good at
Exactly.
these things to move on. Thank you very much for that input. I'm going to move forward to Jicara Collins, who also has quite a bit of experience in the schools. So Jicara, welcome to this panel. And I want to ask you, how do school systems go about training adults who work with youth about LGBTQ population specific needs, and specifically specific needs from the healthcare system?
That's a really good question. And again, thank you for having me. When I got the question, I was thinking like, okay, this is multi-layered. Where do we start? Because being LGBTQ plus is just one layer that young people deal with on a school campus or when they're in healthcare systems. And so what could that really look like? And one of the things, and piggybacking off of Lynn and what she said, is offering training, and not just a one-time, we've checked this box, but ongoing, and offering it to all the staff or any adult on campus that works with young people. You know, identifying trusted organizations that provide LGBTQ training so that they know that what they're getting is what they need to best serve young people. And so I think the first place to start for me, I would say, was teaching compassion. Teaching people how to care for people and about people is where you need to start first. And then from there, you can go into, you know, dive deeper into, you know, some of the hats that people wear, you know, in their everyday life, whether that's their sexual identity, you know, whether that's their, you know, their race and ethnicity and how they identify. So starting with compassion, and showing people how to care for people. And then once we get there, you know, using some of those PD days, and I know trying to get 15 minutes on the agenda is difficult just for me when I'm trying to come in, but really dedicating the time and the space to create a safe environment in schools. And this is one of the ways that you do it. You know, identify who's on your campus and who do we need to make sure feels included and feels safe when they're on campus, and how do we make people how to get people to understand what that looks like. And so I think, yeah, identifying organizations that offer trainings on LGBTQ plus, trainings around implicit bias, which is really important, because someone can think or feel that, you know, I'm inclusive and, you know, outward project unknowingly, and not realize the impact that can have on a young person, because that was not their intention. And so bridging the gap between healthcare and education, sometimes, especially on school campuses where we're providing healthcare services, you know, we'll hear staffing say, well, you know, students are here for academics, you know, and make it all about the academics, where, you know, and not understand that if a child or a young person is healthier, whether that be mentally, physically, or all of the above, they just do better overall. You know, they'll concentrate better in class. You know, they'll be able to give it 100%. If they have something going on that they are more concerned about, that's more important, you know, than this math class at the time, then that's going to take their focus, and you're not going to get that full student's attention, and you're not going to be able to teach them in a way that you feel like you should. And so just understanding how healthcare and academics work together hand in hand so that we can better serve young people.
Jicara, I think from having read the bios, my perception is that you probably have a close ear to the voice of the youth themselves. Like, do you, and I don't want to make too many presumptions too, so correct me if I'm wrong on this one, but in your work with young people, what are they saying? What are you hearing about their experiences, whether positive or negative, in either accessing healthcare or accessing, you know, like positive education experiences?
So I'm not as close as I was when I moved into management. That took me away a little bit. But every chance that I get to interact with young people, I take advantage of the opportunity. But I do have my staff that comes back. They're providing health education in clinical settings, in health clinics on campus, or we're providing education in juvenile hall. So they're having these one-on-one experiences with young people. And oftentimes the experiences that they have make their way back to me, whether they be positive or negative. And we are in an interesting position to where we kind of get the unfiltered version of what young people are feeling. And so, you know, if they have negative experiences, you know, sharing that information with us. And then what I try to do is then go back and share that information with the school sites or whomever may have impacted this young person's experience, so that we can do better by them. You know, often we had an experience with our team, with our medical team, and someone not being as culturally sensitive in a situation where they should have been. There was a young person that came and they identified as trans and had a preferred name that they wanted to use. And so, and the medical system didn't understand that the young person had the right to use this preferred name. They were going by what was in the chart, and kept identifying to this person based on you know, what they were seeing. And so it was one of those teachable moments, and you know, a place where we realized we need to make sure not only are the health educators and the providers culturally sensitive and competent in providing LGBTQ services or just youth-friendly services in general, but the other staff that interact with young people need that same training. So now it's built into our onboarding. Luckily, that young person did return and continued to return, and their experience, once this had been pointed out, was transformed. And so we have a lot of young people also that come in because they feel like the clinical space is their safe space on campus. So sometimes we have to push students out and just say, you know, at the beginning of the conversation, we have 15 minutes together, you know, or give it a time limit. Otherwise, you know, they don't want to go back to class, or, you know, even in checking in with the provider or the nurse, they want to stay and chat with you. And so that speaks volumes. That makes you feel really good, but also, you know, giving them perspective of a real life situation. And, you know, as you go through and move through, you know, these different systems, you're not going to be able to take all the time you want. But, you know, those are ways that we measure a young person's experience, especially when they identify as LGBTQ, and walking them through and helping them get to a place in a space where they feel comfortable, they feel heard, they feel seen, is really important. And we definitely take advantage of those moments when we can, if it's appropriate. It definitely needs to be appropriate. So.
Jicara, some of what you said has inspired some questions that I want to come back and ask the panel after we have talk to Kiku and Gerold as well. But I'd like to come back also and talk about over the last year when schools were primarily digital, like how do we think about teaching compassion when it's real hard to pull someone aside after class when everything has been virtual as well? Like, how do you follow that up? But let me come back to that one. As we move through over to Kiku Johnson. I want to ask you if you can talk about your work in creating change behaviors among those who have struggled to provide culturally competent care. As Jicara was just talking about, someone who could have done a better job, could have provided, we're going to say culturally competent care, but definitely could have been more culturally aware, sensitive, compassionate, and humble. You've had some experience, I think, with this. So in terms of people who have, who could benefit from some of these changes in behavior, what has that work been like, and what are key components to creating that change?
Yeah, thank you for asking that question. And I'm so thrilled to be here with this group and to be able to hear, and I've been able to intersect several of folks on this group in other conversations related. And so to know that we have this patchwork, bringing forth wisdom around what can happen makes me really happy to be here in this moment. So when we think about the behaviors and how can we change them amongst folks who have struggled to provide culturally competent care, I think the competent part is a similar word that I get challenged with, similar to tolerance. I think we are aiming much higher past competency. I think being someone who's nearing 50 on the planet that has experience coming out twice, I'm an out trans male, and I transitioned later in life, just in the last handful of years, that competency and tolerance has been something I've had to wrestle with throughout my own learning and time. So when I think about how can we create these behaviors that change that narrative, it's really for me around cultural humility. It's around that whole package of talking about folks' identities and creating spaces that are safer for people to exist in and to choose to be in. And that looks like entering always with a lens of intersectionality. And I've heard a lot about inclusion and inclusivity and how can we create spaces that way. I also like to aim to a space that's more expansive. How can we transcend that lens? So there's a lot of practices in which we could be looking at differently of how do we build spaces to be ready for the people that are not yet there, are not yet feeling safe to be there. So I think that's a really important step of really not only looking at curricula and processes and systems within institutions and places, and these are schools and healthcare facilities. I think it's important to look at these oppressions that are inextricably tied, because oftentimes conversations will start with, how will we do the work now around race? And next month, we're going to focus on LGBTQI. And the opportunity really is, how do we have all those conversations together? Because me as a person who identifies as Chinese, that's not something that I can have separate, that conversation. That walks into the room as well as my trans identity. And when I'm looking at those pieces, it's all about relationships. You know, I think I was on a Measure X call last week, and someone was speaking about the R's, right? The R's in education, the reading, writing, arithmetic. And I really look at also restorative healing and relationships. That's the stuff that we're not engaging with enough in the practice of everything that we're doing. So I think that that's another key piece is relationships, and how are we building them? How are we building them to also not check a box? How are we building relationships to be in community and partnership for 3-4 years, where we're not looking at how can we complete it within a named month or in response to continued lives being taken because of these inextricably tied identities on our planet. So looking at relationships, looking at cultural humility, intersectionality, and establishing really sustainable learning pathways. And I think that takes investment. Speaking with high school students recently in the county, they were championing and so excited that they had 2 paragraphs in their history book that spoke to queer identities. And I think about 30 years ago when I was in high school, that wasn't even, the word queer was not embraced, nor was it something that you could utter. And I hail from the Midwest. It's a very different region and experience in growing up. I appreciate you talking about being Mormon in that space in your life, David, because I think about there are these systems that we've been taught to abide by and work within. And regionalism is a huge piece. And I've had the opportunity to travel the country and educate across different sectors around sexual orientation, gender identity, and expression. And creating those change behaviors have to do with the relationships and broaching topics and inviting in cultural humility conversations. I think folks need to do that work themselves first before they can be any type of purveyor to young people. And I think young people are actually the ones that are teaching us. They have surpassed us. And so we are playing the catch-up game, and we need to be committed to that. And we need to look at them as our teachers. And so when I look about changing behaviors, it's trusting our young people. It's looking to them to be able to co-create the systems, re-inform them, re-establish them, creating expansive spaces.
Absolutely, and there's really something to be said there for respecting young people as having something to contribute and teach people who are not young people. There was it's interesting that you said I also grew up in the Midwest in a small town in southern Illinois. St. Louis was it was all cornfields and apple orchards, and I remember learning about seatbelt safety in second grade, because when I was in the second grade, nobody wore seatbelts. It just wasn't a thing. And the country, like the public health and safety folks, figured out if we can teach children in grade school about seatbelt safety and get them to seatbelt shame their parents when they get in the car, because it's hard to change adult behavior. But if you can, then basically there's this whole movement to teach children to get in the car, put on their seatbelt, and then encourage their parents to do so as well. And so they actually taught up intentionally. And this is now, when you think about the things that we have learned from TikTok over the last year, I don't know if any of you have started being TikTok scrollers too. It's like the teachings from Gen Z and younger folks about just the whole language, but just about the experience has really been something. So thank you very much for pointing that one out. I think also we should have, if we don't, and Carlin, we need to compile some resources for where training is available and where viewers can get it. And so and be able to distribute that, because I bet you the folks on this panel probably have know what the best trainings are and know what access to those things are as well. Gerold, I wanted to move into you. Thank you very much for your patience being the last person to get addressed on the panel. I would like to ask you about, in the region, Contra Costa, what is access like for healthcare providers and mental health care providers? Is there a dearth? Do you have an overpopulation? Are there long waiting rooms? What's it like for the pipeline of providers into the county? What does that environment look like? And then my follow-up question, of course, is going to be, among the pipeline of providers that are there in the county, how does LGBTQ healthcare, LGBTQ competence in healthcare, I had to use the word again too, so for lack of a better word, it was like at a baseline competence, better cultural humility and capability for working with LGBTQ people. How does that information get disseminated to the providers throughout the county system as well, in order to promote training and proficiency? And if you would rather answer a different question, go for it, but you're also muted.
Thank you, appreciate it. Well, the need is great, and you know, we are you know, we're struggling to you know, really respond to the need that is out there. And I want to connect with something that Kanwarpal brought up earlier today about you know, limitations of the funding models that we operate under, because that is really limiting our ability to respond to the need that is out there. You know, where one has to, folks have to meet certain diagnostic thresholds first before they can get a certain level of services. And when sort of like the very approach that we take often pathologizes the health seeker, when we really need to proactively work with the environment that youth live under or live with. It's about acceptance, relationships, responsiveness to the needs that people are expressing, too often we respond by pathologizing certain ways in which people express their needs. So having said that, we are doing our best to work within those confines, and there are some funding mechanisms that we have available where we are able to support the broader work of awareness building, system change, and do the right thing. Where we partner with organizations like Rainbow, RYSE, NAMI, others, who are really much more closely in touch with the communities that we want to work with. I'm not sure that I really respond to the right question here, the way you asked your question, but I do want to point out that by way of working with those partners and by way of providing trainings within our department and for all of our providers that we contract with, we are trying to build cultural humility, awareness, self-reflection, on one's own assumptions and privileges, and to prepare providers to better respond to the needs that our clients present.
So what do you think, what motivates providers and provider groups to expand their capabilities here to serve?
Well, our providers they see the suffering that some youth experience as a result of not being accepted for the way they express themselves or for the struggles that they go through, and experiencing their own limitations. I think it's the experience of one's own limitations in the helping that we're trying to do that leads to the need for further training, for connecting with organizations and folks that have more experience and are more aligned with communities to be in a better place to do that.
Okay. Well, thank you very much, Gerold, and everyone for a really interesting conversation today. We've got about 5 minutes or so left here to see if we can get to some questions. And so, Carlin, I'll pass it back to you to see if we can get to a first question.
Sure. Well, actually, we've had a very attentive audience, but no one has put a question into the Q&A. So, if folks want to do that, they're welcome. But in the meantime, I just wanted to turn it back to you, David, since you said you had some follow-up. So maybe if you want to ask a follow-up question, we can see if anybody puts anything in the chat. And after that, if not, we can conclude.
Sure, and I appreciate that one too. And so this would go to anybody on the panel. So please, everybody jump in at once, and whoever wants to take this one, please. But with the impacts of everything that happened in 2020, I was actually on another panel last week about the impacts of COVID and shelter-in-place conditions upon LGBTQ populations and how that had a particular impact. I'd love to pose something like that to this group, like when you've had to go digital and when support, like the way that people used to seek support, had to change over last year. How did that impact the work that you do and the outcomes for the people that you seek to serve?
I'd love to jump in really quick on that one. Being a community center in the county, folks were used to coming in person to our location in Concord. And when we closed our doors, that dramatically shifted who actually got access. So to see the disparities show up so clearly around who had devices, who had safe spaces to be able to zoom in from and could be out, if you will, and who had that access really made the whole demographic of who actually we serve change, and not for the better. I would say that it really showed who actually were given resources differently, already had them. And that had a lot to do with our food insecurity and our youth program and our houseless program, to see the difference of the color of folks that were showing up. They were not the people that actually needed it the most. And knowing that that shouldn't be rocket science, but I think that is actually a really sad impact of this time. That has been glaringly obvious. Otherwise, it's been differently helpful for other people, of course, to be able to be reliable and have greater attendance in different ways, even de-siloing who comes to programming from other states, from places that are more isolated, if you will. So that's something that I wanted to make sure to share out loud.
Thank you very much.
I think I wanted to jump in here as well, because of course, we shifted all of our programs to Zoom at NAMI. So we also had staff that were really wanting to have one-on-one appointments with people. And so we might have broke a couple of the rules as essential workers and go out. But we noticed, and I noticed, sometimes people ask me why on my resume or on my bio do I say my focus is working with African-American, and sometimes I say African-American male community to reduce the disparities. It's because, in my humble opinion, but supported by data, that's the most harmed community. And I really feel like if you start, and whenever we do any reports and we look at ethnic data, you're always gonna find the community hurt most is African-Americans. And we found that out around COVID-19 as well. So there's no language barriers, but because of systemic racism, we see that that community is suffering most even now, even with the HIV/AIDS crisis, as other communities moved on, it's still very much a pandemic for African-Americans. So my belief system from a public health platform, if you start with the community with the worst outcome, you can benefit all communities. And so even when we look at the LGBTQ community, and we start looking at who has the lowest wages, who has the homelessness issues, it's the Black individuals who are from that community. So I feel very justified, and I have a new partnership with the Rainbow Center. When we get phone calls, we know we're not the subject matter experts. So when we had our Measure X opportunity to speak that I fought hard for, I'm gonna make space. And I think we all have to do that, whether you're from the community or an ally. You have to make space for the communities that are harmed. You got to look around the room and you got to say, let me take what little privilege I have and make space for the community that needs to be heard most. So we'll always do that at NAMI.
I'm glad you said that. A white gay friend of mine, when we were talking about when we're going to take our masks off in public, he said, I'm going to watch Black trans women, because if Black trans women are taking their masks, like we want to talk about, I think it speaks to what you were talking about, is like when we know what population knows what's up, like I'm going to follow their lead on this. And I say that a little bit playfully, of course, but I think it speaks a little bit to knowing, like, when you look at who has the most complicated access to good services, serve that population first, and people will cascade in, hopefully. We've come to 3 o'clock. So Carlin, I'm not gonna be the 3 o'clock hatchet person. So I'll let you take on that role and take us home.
Okay, great. Well, I want to thank everyone. This has been such a powerful conversation, and we didn't receive any questions, but we did hear from one of our attendees, Sandy Colon, who is sharing that she thinks it's amazing to hear all of the panelists speak about the importance of inclusion today. She's a clinical counseling graduate student hoping to work with the LGBTQ+ community in her near future. And she just feels it's very heartwarming to know that there are so many people like each and every one of you in the community who are working to better services for everyone. So I wanted to share that and thank everyone for participating in this engaging and thoughtful conversation. And as wrap up, you know, I hope that everyone who has participated in today's conversation, whether as a panelist or attendee, we've all had the opportunity to learn from one another. So I just want to encourage everyone to take the learnings back to each of our organizations, share, evaluate what we've heard and what it would take within our individual spheres of influence to initiate systems change within our networks. I know that David is already working on that with Blue Shield of California, and my team is as well. And I'm happy to loop back with all the panelists to gather resources to share with the greater community, because we've heard reference to several here today, and so I think that it would be helpful. I'm happy to convene that sharing. I also wanted to let folks know, and a special thank you to Kanwarpal. You know, she had pointed out to me when I'd reached out to invite some young people to participate in this panel that it really would be much more appropriate to have a youth panel facilitated by a young person with lived experience. And I know we talked about the importance of amplifying youth voices. And so I look forward to the opportunity to connecting with Kanwarpal to organize that convening. And we've talked about organizing that for late summer. So please stay tuned for that information. So I just want to say thank you to everyone. Please do feel free to share the recording and this conversation with others. And I look forward to continuing to work with each and every one of you on culturally responsive and inclusive healthcare. Thank you very much.